Hello viewers, this is Reshma Tirupati, Senior Nursing Officer working at ESIC Hospital, Hyderabad, Telangana. So today we will be discussing about medical and surgical nursing questions, that is MCQs we will be discussing. So along with the questions, I would also like to discuss the anatomy and physiology of that particular system. For example, if I am discussing about genitourinary system, I also want you people to know about the anatomy of the kidneys. If I am discussing about the appendicitis, I want you to know about the anatomy of the large intestine and how the disease occurs. So the meaning behind this taking this anatomy and physiology here is, once you know the normal condition of any particular organ, then you will be knowing what is the abnormal thing. So it will be very easy for us to differentiate between what is a normal organ and what is a differentiated or abnormal organ. So how the disease condition is going to affect the system. So let's start the session. So here the first question is, an adult is admitted with chronic renal failure. Strict intake and output is ordered. The client is sometimes incontinent. So incontinent is, so here they are already mentioned that client is incontinent. Means the client he doesn't have control over the urine output or urine whatever he is passing. So it is impossible to obtain an accurate record of output. So how can the nurse best assess the client's fluid status? So the given options are: estimate the amount voided each time. So every time when the patient is voiding the urine, so you are going to measure that one, and observe the skin turgor, the skin integrity, how it is dry, clammy, wet, or the patient is puffing, sweating. All these things we are going to observe in skin turgor. Or weigh the patient daily, checking the patient weight daily. Or record the number of voidings. Record the number of voiding means how many times the patient is actually voiding the urine. So what will be the best option for this particular question? So here the condition what they have given is chronic renal failure. So chronic renal failure is, so we should also know about the genitourinary system, what is a normal kidney looks like. So let's see one by one. So let us see one by one. So here we have so this is a normal kidney. Can you look at the kidney? So the kidney is usually located in a retroperitoneal way. That is, it is located in the peritoneal organ and in the peritoneum organ. So if you look at, this is the 11th rib, thoracic ribs are protecting, that is 11th and as well as 12th rib will be protecting the kidneys on the right side as well as on the left side, and the kidney is having a fibrous capsule around the kidney, both the kidneys, and this is renal pelvis. So whatever the urine getting collected, it will be going to the urinary bladder through the renal pelvis, and this is diaphragm. So when you look at the diaphragm, so the upper portion, superior portion is, this is diaphragm. This is 11th and 12th rib, and this is a quadratus lumborum muscle. So these are the muscles, it will be there. So when you look at the kidneys, right kidney will be somewhat lower in position because the right portion is occupied most of the time. Right kidney is occupied by the liver compared to the left kidney. Left kidney will be located at the 11th and 12th, but right one will be somewhat little bit lower in the position. So let's look at the cross section of the kidney. So once you look at the cross section of the kidney, so the outermost layer of the kidney is called as fibrous capsule of the kidney, or this is the fibrous outer layer, which is in greenish color for highlighting that. Then the next one is fat body of renal sinus. So this is the fat body of the renal sinus. Then the minor calyx. So this is the minor calyx. So minor calyx will be coming out of each and every pyramid. So when you look at the overall kidney, outer layer is the fibrous capsule, and the next to the fibrous capsule we will find the outer layer of the cortex. So next to the cortex we will find these pyramids. So these are called the renal pyramids. This is called the cortex, and these are triangular in shape. So in the triangular shape of the renal pyramid, you can find at the bottom the whitish color. This is the renal papillae. So this is the renal papillae. So all the nephrons or the nephrons you can find in this region. So the nephrons elongating and the urine will be collected in the papillary region. Then, so once the urine is getting collected, it will come down through the minor calyx. So these are the minor calyx coming out of each and every pyramid. So if you look at all this minor calyx, all the minor calyx will come and join to form the major calyx. This is the major calyx. The highlighted green portion, is it visible to you? Then renal pelvis. So all the major calyx, they will form the renal pelvis. Here you can see the renal pelvis, all the urine getting collected in the renal pelvis region. Then we look at the interlobar artery of the kidney. So these are the arteries. Can you see each and every is supplied to the pyramid? Here there is a interlobar. Between each and every lobule we can see the blood supply. Then interlobar vein of right kidney. So this blue color colorations, these are called as the veins. Then next one is renal cortex. Renal cortex is the outermost layer. Then renal artery I have shown you. Renal vein, this is the main vein where the kidney will be receiving the blood supply. Then the inferior segment of the artery of the kidney. So this is the inferior segment. So when you look at the outer layer, this is called as cortex, and its middle portion, this is called the medulla. So in between the pyramids, the cortex of the kidney will have projections. These are called as the columns. So can you see the columns? So columns, pyramids, cortex, this middle portion is called as medulla, and here we have pyramids. Then these are called as minor calyx, then major calyx, then renal pelvis. And this particular area is called as the renal pelvis. Here in the renal pelvis, we will have the entry and exit of all the nerves, blood supply, lymphatic tissue. All the entry and exit portion is called as the hilum of the kidney. So when you look at the kidney, just now I have told you this is called as renal hilum, where we can see the entry and exit of lymphatic vessels, nerves, ureter and blood vessels. And when you look at the blood supply to the kidney, around 20 to 25% of the renal arteries receive direct cardiac output to the kidneys. So around 20 to 25% of the cardiac output we are receiving to the kidneys. And this is, the kidneys are retroperitoneal, that is, it is located behind the abdomen or the peritoneal cavity, and it is protected by the 11th and 12th rib. So when there is any fracture or injury to the 11th rib or 12th rib, you can find there will be a external injury to the kidneys on the bilateral side, which are located on the bilateral side. So when you look at the kidneys are around 10 to 12 centimeters long, and when you look at the width of the kidney, length is around 10 to 12 centimeters and it is around 5 to 7 centimeters wide. When you look at the weight of the kidney, it is around 130 to 150 grams. So just now in the previous image I have shown you, this is the renal cortex, and the middle portion here you can see this is the medulla, and the columns in between the pyramids is called as the columns, and these are the pyramids, and papilla is the whitish color portion is called as the papilla. So through the papilla, so here you can see the nephron. So if you look at the nephron, so nephron's Bowman's capsule is located in the cortex region, whereas the rest of the proximal convoluted tubule, distal convoluted tubule, everything it is located here. So proximal and distal convoluted tubule comes down where we have a collecting duct. Through collecting duct in the papillary region, here we have papillary duct. From the papillary duct we are going to receive the minor calyx, the filtered urine. Then this is called the major calyx, and from major calyx we are going to get into the renal pelvis. So this is the renal pelvis, and ureter is complete combined urine. Here through ureter it will go to the urinary bladder. Hope this image is clear to all of you. So when you look at the what volume of blood enters the renal arteries per minute, if at all any questions comes in the exam regarding what volume of blood is entering the kidney, then we can say that around 1200 ml per minute of blood is the kidney will receive. So let's look at the functional unit of the kidney. These are the nephrons which play a very vital role. So nephrons are also known as the functional unit of the kidneys. So here as shown in the image, so here we can see the Bowman's capsule, and these are the proximal and distal convoluted tubule. So when you look at the complete Bowman's capsule, it actually looks this way. So this is called as the Bowman's capsule or glomerular capsule or glomerulus. This is the glomerulus. So the duct, the proximal convoluted tubule means, so whichever is close to the glomerulus, that is called as the proximal convoluted tubule, and the tubule which is coming down is called as descending limb of the nephron loop. Once you look at the descending loop, again we have loop of Henle here, and which is going upwards is called as distal convoluted tubule. Distal means which is far away from the glomerulus, that's why this is called as distal convoluted tubule. And this one, which one is going up, that is called as ascending limb of nephron loop or the ascending loop. So this is proximal convoluted tubule, this is distal convoluted tubule, this is loop of Henle. This is the descending one means which is coming down, ascending is which one is going up. So hope this explanation is enough to understand what is this glomerulus and what it does. So when you look at this proximal convoluted tubule or look at the total Bowman's capsule, so when you look at this Bowman's capsule, here we can see the entry and exit of this afferent and efferent arteriole. So the renal artery, here you can see the renal artery. From the renal artery, here goes the afferent arteriole. So afferent arteriole is nothing but the entry. So it starts with A. Afferent arteriole, here you can see the afferent, and the diameter of this particular artery is somewhat bigger, whereas the leaving one from the, here is the corpuscle, and the whatever the artery which is leaving, that is called as efferent. So which one is entering is called as afferent arteriole, and which one is leaving the Bowman's capsule is called as efferent, and the diameter of this particular afferent arteriole is somewhat bigger, because it has to go with the more pressure, causing more filtration of the urine. And once the absorption of ions, removal of everything happens here in the glomerulus, and all the urine will be collected from the proximal loop of Henle, distal convoluted tubule, it will grow through this way. So this is afferent, this is efferent. So when you look at the cross section of the kidney, here this is the renal capsule, afferent arteriole, efferent arteriole, and the blood supplies, this is called as peritubular capillary. So whatever is covering this proximal distal convoluted tubule, these are called as the peritubal capillary. Can you see around the loop of Henle and this tubule? So that is called as peritubular capillary. And whatever the urine that has been filtered, it will come through this way, and that is through the collecting duct, it will go into the papillary duct. So this is nothing but this cross section is nothing but one pyramid. So through this collecting duct, the renal papilla, this is the end of the renal papillae, and the minor calyx starts here. So flow of the fluid through the cortical nephron, through the glomerulus, Bowman's capsule, we can find the urine getting filtered, then it will go to proximal convoluted tubule, then to the descending limb of the nephron loop, and to the ascending, and totally it will drain into the, finally into the collecting duct. So when you look at the complete, how this urine getting filtered, what is the GFR rate, everything we will see here. So glomerular filtration, this is called as 3 steps mainly takes place here in this glomerulus. One is glomerular filtration, and tubular reabsorption, and tubular secretion. So in this excuse me. Here the artery, whichever the afferent arteriole, whichever is entering the glomerulus capsule. So here the glomerulus, here the blood is dissolved and smaller substances other than proteins is going to enter this collecting duct. And the afferent arteriole, whichever is leaving, here the first process, that is glomerular filtration, takes place here. And the next is tubular reabsorption. So here in the tubular reabsorption, you can find the renal tubule collecting duct, water, ion, substances. Everything will be reabsorbed here. So here everything will be reabsorbed. Reabsorbed, you can see water, ions, other substances get absorbed here in the blood. So here the process, here it is coming out. Whereas tubular secretion, so in the tubular secretion, if any such as any waste, drugs, excess ions get secreted from the peritubular cablus into the renal tubule. For example, any penicillin injection is, patient has receiving penicillin injection. So or the drug toxic will be from the peritubular artery, it will go into the urine and it will be excreted from there. So these are the 3 steps. So on an average, when you look, daily volume of glomerular filtrate rate in adults is around 150 liters in female. So it is around 150 liters in female, and more than 99% of the glomerular filtrate returns to the bloodstream via tubular reabsorption. So only 1 to 2 liters about is excreted as urine. So total volume of blood is not going to turn into urine and it is not going to excreted. Only 1 to 2 liter will be excreted here. So next we will look at the causes of the chronic renal failure. So when you look at the disease condition renal failure, so here I have the causes of renal failure. So why is this renal failure is getting caused? So there is renal failure or this renal infections, how it will start. So when you look at the chart, you'll understand. So here we are going to see the acute renal failure. So the main causes of this acute renal failure is, first one is pre-renal. So pre-renal is, here we can see the kidneys, where the kidneys are not involved, like shock, congestive heart failure, sepsis, anaphylactic reaction, pulmonary embolism. I have gathered pictures of this particular here. I have. So these are the pre-renal. So these are the pre-renal causes. So when you look at the pre-renal, here we have pulmonary embolism. So when you look at the artery, which is blood supply carrying to the lungs, here there will have a blood blockage, any clot. That is one reason for this renal failure. And the patient has congestive heart failure. And when there is any renal artery stenosis, when you look at the renal artery stenosis is narrowing of the artery. Due to that, there will be a decreased blood supply to the kidney. Then anaphylactic reaction. If the patient has any anaphylactic reaction, that time we can find this acute renal failure. And cardiac tamponade. Cardiac tamponade is when you look at the outer layer of the heart, the pericardial sac. So pericardial sac, there is a fluid buildup in that pericardial sac, that is called as the cardiac tamponade. Whether it can be a blood or fluid in the pericardial sac, that is called as cardiac tamponade. So all these things comes under the pre-renal causes of the renal failure. When you look at the intrarenal, so here in the intrarenal, when you look at something which is happening inside of the kidneys, here you can see that is inflammation of the nephrons, that is nephritis. Then tubular necrosis. So these so acute tubular necrosis is the afferent arterial constriction, the blood supply which is entering the glomerulus, its necrosis. Then vasculitis and glomerulonephritis, inflammation of the complete Bowman's capsule or complete pyramid. So whatever the organs is present, that is called as glomerulonephritis. Then hepatorenal syndrome. So hepatorenal syndrome is a condition where when there is any abnormality or the liver issues is going to directly show effect on the kidneys also, that is called as hepatorenal syndrome. So all these things are the causes of intrarenal failure. So these are the intrarenal failure causes. Then postrenal causes. So postrenal causes here, So that is benign prostatic hyperplasia. Benign prostatic hyperplasia is inflammation. So for especially in the males, we can find the inflammation of this prostate gland is completely going to obstruct the urethral opening. Due to that, the urine will be collected and the patient will be unable to pass the urine. Then urethral obstruction. So these are both are the kidneys. This is artery, this is vein. So when the urethral opening obstruction due to this inflammation of the prostate gland, or in females other reasons which may cause this hydronephrosis, due to this urethral blockage, all the urine will not be excreted through the urethra or through the urinary bladder, and there will be complete dilatation of these ureters from the kidney. Then bladder atony. Bladder atony is nothing but the contraction of the bladder muscles. Here the contraction of the bladder, involuntary contraction of the muscles on all the wall of the bladder. Then cervical cancer, especially in females. So this is how a normal uterus looks like, the normal cervix looks like. When the patient is suffering from cervical cancer, the cervix will looks like this. So these are the causes of postrenal. So here we can understand what are the pre-renal, intrarenal and post-renal causes. So because of these things, there will be a decreased blood flow and decreased oxygen to the kidneys. So because of this decreased blood flow and oxygen to the kidneys and obstruction and backup of urine with pressure, the urine will not be excreted, leading to the cause of tissue damage. When you look at the normal glomerular filtration rate, it is around 90 to 120 ml per minute. Due to this GFR will be decreased and the tubular function and the hormone secretion also will be decreased, because the kidneys produce this erythropoietin hormone which is necessary for RBC production, and renin hormone which is essential for which is very essential for reducing the blood pressure. So all this will be hampered. And also chronic renal failure, we can see chronic renal failure. So because of this chronic renal failure, what will happen? Fluid overload, that is congestive heart failure, then metabolic acidosis, hyperkalemia. So all these are the causes of the pathophysiology of the renal failure. So here in the given options, when you look at the given options here, so estimate the amount voided each time. Because the patient is already incontinent, we don't know how much urine the patient is voiding each time. And skin turgor is not the accurate way to measure the the fluid status of that particular client. And recording the number of voidings. Recording the number of voidings is not also this is not the correct answer. So we need to check the patient daily. So checking the patient daily is only going to help us. So daily weights are the best way to access fluid balance. Estimations of the amount of urine voided is not accurate, and so checking the daily weight of the patient is the best method to know the patient fluid status. Then just by looking at the picture, now you will be able to understand what is this question is about. So here we are going to see the question related to the hemorrhoids. So here the question is, the client has just returned to the nursing care unit following a hemorrhoidectomy. So what order should the nurse expect? Sitz bath, stat, or immediately whether it should be given QID 4 times a day, or warm compress to the surgical area as needed, a hot water bottle to the surgical area as needed, or an ice pack to the surgical area. So what about the So let's look at this hemorrhoids in detail now. So when you look at the hemorrhoids usually we can see at the rectal region. in the patients, and almost 50% of the population do have this hemorrhoids problem here. So these hemorrhoids are of two types. One is internal hemorrhoid and the other is external hemorrhoid. External hemorrhoid, which is visible to the naked eye and which are finger-like projections which are present outside the rectum region. These are called as external hemorrhoids. And internal hemorrhoids are which are present above the internal sphincter. This is external. External sphincter, which is a voluntary one, which is under a motor control, which is under our control. Involuntary. Internal sphincters are involuntary. This is above the involuntary muscle, involuntary internal sphincter, we can find the internal hemorrhoids. And fistula. Fistula is the crack at the cano-shaped crack at the rectum, anal fissures or anal ulcers. So when you look at this anal canal, this is rectum and this is anal canal. And here this is internal anal sphincter. This is internal anal sphincter and this portion is called as anus, and these are anal columns. You can see this here. This is anal columns and the external anal sphincter, which is voluntary in nature, and this is internal anal sphincter, which is involuntary in nature. So when you look at the hemorrhoids, these are dilated varicose veins of the anal canal. It can be internal, external or prolapsed. Prolapse is the finger-like projections from the internal hemorrhoids. It will be protruding outside of the rectum, and these internal hemorrhoids lie above the anal sphincter and it can be only felt when there is a perianal inspection of the perianal area. And external hemorrhoids lies below the anal sphincter, which is easily visible on inspection. And prolapsed hemorrhoids, which become thrombosed. Prolapsed is the hemorrhoids which are prolapsed, which contains blood clots, which becomes thrombosed and inflamed. Then hemorrhoids are caused due to portal hypertension, straining, irritation or increased venous or abdominal pressure. So how we are going to assess this hemorrhoids? When the patient is complaining of bright red bleeding during defecation and rectal pain, and the patient will also complain of this rectal itching. And when I look at this rectum, it is around 15 centimeters long. It is located anterior to the sacrum and coccyx. So here we can see, when you look at the renal pelvis bone, just before the sacrum we will find this anterior portion of the rectum, and the terminal portion is 2 to 3 centimeter long. And the anal mucous membrane arranged in anal columns containing this contains arteries and veins. So anus opening so that's how I have told about this sphincters. Then when you look at the interventions for this hemorrhoids, first initial should be apply cold pack to the anal rectal area, followed by sitz bath as prescribed. So immediately on the day of surgery, we will be advising only cold packs. The next day we should start the sitz bath. So apply topical anesthesias as prescribed and encourage a high fiber diet. So the patient will not be taking adequate fluids, or the patient is not including enough roughage in the diet, including enough fiber rich diet and fluids to promote bowel movement without straining. So Valsalva maneuver, you might have heard of Valsalva maneuver, where the patient will be straining too much to eliminate or to empty the bowel. Then administer stool softness. Stool softness like lactulose syrup can be given, should be prescribed to the patient. Then surgical interventions, I will show the images of the surgical interventions. So the surgical interventions are sclerotherapy, circular stapling, ligation and resection of the hemorrhoids. So when you look at the hemorrhoids, so this is the exact location. So mostly who are more prone to get this hemorrhoids is the patients who are office work, like drivers, those who are doing this prolonged sitting work, that kind of people are more prone to get, and those who take less intake of fluid, less fiber in their diet. And pregnant women, especially in postnatal time or in antenatal time, due to the pregnant women have this hemorrhoids. Usually either they will get it during the pregnancy time, or during the pregnancy time, or their existing hemorrhoids will get aggravated during the pregnancy period. So when the client is having this many issues, they must visit the doctor. And when you look at the signs and symptoms, the client will be complaining of itching around the anal region, then bleeding around the when they strain too much, there will be bleeding, and obesity, more body weight, stress. So appropriate medications to be given to the patient. When the patients will also come with the complaints of pain, bright red bleeding through during defecation. So what and all things we should advise to the patient? So we should advise the patient about good personal hygiene, avoiding excessive straining, that is avoid soluble maneuver or straining, and add more high fiber rich diet, less spicy diet, and a combination of warm compresses, sitz bath, analgesics, painkillers, ointments, all to be advised to the patient. So when you look at the non-surgical treatment, it includes infrared coagulation, bipolar diathermy, and laser diathermy. And rubber band ligation is also a procedure for internal hemorrhoids. Then cryosurgical hemorrhoidectomy. Cryosurgical is nothing but freezing the hemorrhoids. Later it will cause, the freezing of the hemorrhoids will cause necrosis. But this is not widely practiced due to the foul odor. So once it is in the process of healing, the necrosed hemorrhoids will cause very bad odor, bad smell, and it will cause more prolonged wound healing, not an immediate one, but a prolonged in nature. Then another one is ND-YAG laser. It is excising means complete removal of hemorrhoids, and the tags. So when you look at the infrared coagulation, so here infrared coagulation, that is grade 1 internal hemorrhoids. This particular treatment is useful for grade 1 and grade 2 internal hemorrhoids. Then when there is any internal bleeding hemorrhoids and the patient, if he is not suitable for surgery, for them this infrared coagulation is useful. Then the other one is bipolar diathermy. So in bipolar diathermy, so exactly the location we are going to give the patient is going to get the treatment. Then there are several other types. Then this is banded hemorrhoid. So when you look at this internal hemorrhoid, they are completely, a rubber band ligation is put at the neck of the hemorrhoid so that later it will get necrosed and it will fall. So this is a proctoscope. Through proctoscope they are visualizing and they are tying that, ligating that hemorrhoid. Then closed hemorrhoidectomy. So in closed hemorrhoidectomy, they are doing hemorrhoid excision, means removal or cutting the hemorrhoids here in the beneath, in this region they are cutting, and after that they are going to suture this line leading to wound closure. Then stapled hemorrhoidectomy for prolapsing hemorrhoids. Prolapsing means which already thrombosed, foul smelling, thrombosed, which already has blood clots. For those type of hemorrhoidectomy, we will advise this one, that is suturing the hemorrhoid tissue to stapler. This is a complete hemorrhoid excision. So through proctoscope this will be introduced. There they are going to suture it. Here you can see. So firing of the circular stapler, then they are going to remove it so that there will not be, and the patient will be on the liquid diet. Then so when you look at the answer for this question, so the client will have an ice pack. So the client will have an ice pack applied to the surgical area on the day of surgery. So immediately after hemorrhoidectomy, we are not going to advise sitz bath. Sitz bath is going to be advised only on the next day. But on the 0 day, we are going to advise the client to take ice pack applied to the surgical area. Sitz bath will be ordered following day, and the rule is cold for the first 24 hours. So in the first 24 hours, we are going to advise. So it will prevent edema. It will prevent edema, followed by warmth to promote healing. The day after the surgery, the client will start taking. So after the day, the patient will be receiving this sitz bath. Next we will see the question. So the next question is, okay. So the next question is, an 18-year-old is admitted with an acute onset of right lower quadrant pain at McBurney's point. So appendicitis is suspected. So here we are suspecting appendicitis in the patient, for which clinical indicator should the nurse assess the client to determine if the pain is secondary to the appendicitis. So an 18-year-old patient is complaining of pain at the McBurney's point. So McBurney's point is the imaginary line drawn from the umbilical region to the anterior superior iliac spine. So we will get this McBurney's point. So here appendicitis is suspected. So for which clinical indicator should the nurse assess? So what are its, so how we are going to, there are certain terms where we are going to assess the appendicitis, that is urinary retention, gastric hyperacidity, rebound tenderness, or increased lower bowel motility. So which would be the, so which intervention will be correct, or which answer is correct? So before knowing this exactly what is this appendicitis, what are the abdominal organs, we should know, and where it is located exactly. So when we look at the abdomen, so here we have in the abdominal region, the abdomen is divided into 4 quadrants or 9 regions. So the McBurney's point is located at the anterior superior iliac spine. From the umbilicus, when there is imaginary line is drawn from the umbilicus to the anterior superior iliac spine, in the 1/3 of the area we are going to palpate the McBurney's point. So it is, so look at the abdomen, it is divided into 4 equal quadrants, that is right upper quadrant. So when the patient is having this appendicitis, the patient will complain a pain of right lower quadrant in this region, and this is left upper quadrant, and this is left lower quadrant. So appendix is nothing but, usually they call it as vermiform appendix. Vermiform appendix. So here the vermiform means worm-like structure. Worm-like structure means అంటే అది పురుగులాగా ఉంటుంది. It's almost 10 centimeter long. So it looks like a worm, and it is a vermiform appendix. Right now it doesn't play or it have any active role in the human body, but it is present. It is 10 centimeter in length. It is a finger-like appendage, and it is attached to the cecum. It is when you look at the ascending colon, we will find this cecum region. There near the ileocecal wall we will find this one. So the appendix is prone to obstruction, and it is particularly vulnerable to infection causing appendicitis. When you look at this clinical manifestations of this appendicitis, here the patient will have a vague epigastric pain or periumbilical pain. So epigastric region is, here you can find this epigastric region. Here we will have this epigastric region. Okay, so let me also show, along with that 4 quadrant, these are the 9 regions which we have to know when it comes to this appendicitis. So this is right hypochondriac region. So in the right hypochondriac region, when the patient has any pain related to liver, gallbladder, right kidney, small intestine, here the patient will complain of pain at the right hypochondriac region. And this is epigastric region. So here in the epigastric region, near the stomach, you can find this liver, pancreas, duodenum. Here this is called as epigastric region. Then coming to the left, here the spleen, colon, left kidney, pancreas. So here we will find this left hypochondria. Then lumbar ante veepu. This is right lumbar region, gallbladder, liver, right colon here. This is the ascending colon we can find here. And umbilical region near the navel, intestine or duodenum related any issues. This is the umbilical region, and this is lumbar, right lumbar, left lumbar. Then this is right iliac. So when you look at this renal pelvis bone, here we will find this right iliac. Any appendix issues, cecum. That is, here you can find this appendix. Then this is hypogastric region and this is left iliac region. So exactly being we have in this medical profession, nursing profession, you should be telling the patient is complaining of pain in the right lower quadrant or right iliac region, or the patient is having this epigastric burn, or the patient is having a burning sensation near the epigastric region, umbilical region. These 9 regions we are supposed to know. Then rebound tenderness occur when the pressure is released. So rebound tenderness is when we are applying, the patient will have pain on the right lower quadrant. So when we are applying pressure, palpating the right lower quadrant, when you are applying pressure, the patient will not have any pain. When you are releasing your hand, that time the patient will complain of pain. And the pain and tenderness will also be present. And if the patient is complaining of pain during defecation, when he is passing motions, the patient is complaining of pain, it indicates that appendix tip is near the rectum. Means near the rectum at the posterior region, the appendix is paining. Then pain on urination. If the patient is having appendicitis along with when the patient is passing urine and if he is feeling pain, it indicates that the appendix tip is near the urinary bladder. Then when the patient pain, when the appendicitis is unnoticed or the patient is not turning up within 24 hours, so at that time there will be happening this rupture of the appendix, then peritonitis, abdominal distension. So all these complications will occur. So other things like constipation can occur with acute process like appendicitis. Because of this appendicitis, there will be paralytic ileus of the abdomen, means there will not be any, most of the bowel movements will be prolapsed, and laxate is like lactulose syrup or suppository should not be advised to the patient when the patient has symptoms like fever, nausea or pain. When you look at the pathophysiology of the appendicitis, it mostly occurs due to inflamed appendix, means swelling of the appendix due to fecal obstruction, hard stool, stuffed stool, due to lack of adequate fluid status. There will be fecal obstruction. The presence of any tumor, it may be a benign or malignant tumor, or any foreign body presence like ascaris, like worms, all these things. Then due to that, there will be inflammation increasing in the intraromular pressure. So within the 10 centimeter appendix, there will be increased pressure, causing more severe abdominal pain, and the pain becomes localized. So patient will be most of the time complaining at the lower quadrant, and the inflamed appendix will fill with pus later if not getting treatment. So this is the so when you look at this large intestine, so this is how a large intestine looks like. So which one is going up? This is called as ascending colon, this is transverse colon, this one, and this is descending colon, and this is S-shaped here, that is called as sigmoid colon, and this is rectum, this is anal canal, and this is anus. So here you can find this vermiform appendix. So this is the appendix which is 10 centimeter long. So here this is ileocecal valve. This is ileocecal valve. And omental appendices. Omental appendices, these are the smooth muscle projections we can find around this large intestine. And right colic hepatic flexure. So the meaning of this right colic hepatic flexure is the sharp bend of the ascending and transverse colon, that is called as right colic flexure or hepatic near the liver. Then this is left colic flexure, that is the folding of this transverse colon near the descending colon, that is called as left colic flexure. And omental appendices, so these are the omental appendices. Ostra is, you can see this bun shaped structure. So when the food is getting absorbed, or the chyme is nothing but the food which will be having this, due to peristalsis it will be propelling forward, moving forward. So that particular shape is called as ostra. Understood? So haustral churning means the movement of the food. It is moving forward. That is called as haustral churning. And the bacteria in the large intestine converts the protein into, here the bacteria whichever is present in the large intestine, it will convert into amino acids, and it also produces B vitamins and vitamin K. Because in newborns also, because the newborn babies, their gut is sterile, that's why we will give this vitamin K injection. And absorption of nutrients, everything happens in the large intestine, and defecation also process happens here. So here we have seen this Taenia coli. So what is the exact meaning of this Taenia coli is 3 bands of longitudinal smooth muscle. So this longitudinal smooth muscle is called as Taenia coli, and haustra is the small pouches, colon folds. So when you look at the main important terminologies which will be most of the time will be using in this appendicitis, 3 terms will be McBurney's point, rebound tenderness, and Rosing sign. So when you have told that McBurney's point is nothing but anterior superior iliac spine, which will be here, and this is umbilicus. So 1/3, when you draw an imaginary line from there to this anterior iliac spine, here you will locate this McBurney's point. So the patient will complain exactly here, local tenderness here in this region. Then rebound tenderness. So in the rebound tenderness, production or intensification of pain when the pressure is released. So when we want to examine the patient, when you palpating this region, the patient will not have pain, but once you release your palpation, once you stop palpating, the patient will complain of rebound tenderness. Then the next one is Rosing sign. So Rosing sign is when you are palpating on the left side. So when we are palpating or deep palpation or light palpation on the left side, the patient will have a causing pain on the paradoxically on this side, on the right side. Left side palpation will cause pain on the right side, that is Rosing sign. So hope you understand these terms. McBurney's point, rebound tenderness, when releasing the patient will complain of pain, and Rosing sign is when left side is palpated, the patient will complain of the on the right side. So here the option answer will be rebound tenderness is a classic subjective sign of the appendicitis. And other options whichever given here was urinary retention, it will not cause lower right quadrant pain. And other options were like hyperacidity. Hyperacidity is located in the epigastric region, not near the lower right quadrant. And there generally is decreased bowel motility distal to an inflamed appendix. So inflamed appendix, it is far away from this bowel motility. So this is how where our session ends. Thank you.